Our next presenter, Dr. Mohammad Naimul Haq. Dr. Naim, please. He is from Rajshahi. It is also very close to India. There is Indian border. Rajshahi, Dr. Naimul Haq, please.
Sir, share your screen. Okay.
This is Yusuf.
Am I seen now?
Or you want to tell us right now, Dr. Yusuf?
If you permit.
Okay.
You can
Full
continue.
screen is not available. Full screen, please.
Full screen.
Otherwise, the slide will not move.
Yes.
Yes.
Now it is full screen.
Yes, Assalamu alaikum. I, Dr. A.N.M. Yusuf from Sylhet, is presenting the role of intravitreal injections in retinal pathology, my experience in Sylhet, the northeast part of Bangladesh. This is the part of Sylhet you see here in the red color. This is the beautiful sceneries of Sylhet. Sylhet is known as the tea capital of tea in Bangladesh. They are the beautiful sceneries of Sylhet. It is also the land of saints. And you can also see the clouds over the top of the trees, and they climb from the tree down to the river and the crystal clear water here. So my topic, the intravitreal injections. These are the therapeutic agents inside the vitreous cavity through pars plana and aseptic precautions. History of intravitreal injections. In 1980 to 2000, antibiotic for endophthalmitis was used, and also CNV retinitis. 2002 2004, steroid triamcinolone was used, and 2005 to 2006, the anti-VEGF era begins. There are different routes for drug delivery system. Intravitreal use of drugs are chosen because of their easy availability in the area of action and quick onset of action there. Presently, drugs used intravitreally are anti-VEGF, pegfilgrastim, bevacizumab, ranibizumab, aflibercept, anti-infective, antibacterial, antiviral, steroid dexamethasone, triamcinolone, gases, AR, sulfur hexafluoride, perfluoroethane, perfluoropropane, etc. Surgical anatomy. The site of injection is pars plana. Here you see the ciliary body. Here is the pars plana, which is the posterior part of the ciliary body. And there is a linear relationship exists between the axial length of the eye and the pars plana. So during the development, during giving injection, we have to take in care about the age of the patient. If the age is 1 to 6 months, then the injection site will be 1.5 millimeter away from the limbus. In case of 6 months to 1 year, it will be 2 millimeter, and 1 year to 2 years, it will be 2.5 millimeter away from the limbus, and 2 years to 6 years, it is 3 millimeter. And in case of 7 and onward, the injection site will be 4 millimeter in phakic eyes, and 3.5 millimeter in pseudophakic eyes, and 3 millimeter in aphakic eyes. What should we assess before giving injection? We should have a full history, and systemic examinations should be done for any systemic diseases. Adnexal anterior chamber infection should be treated first. Informed written consent should be taken. Any routine topical medication should be continued. Glaucoma should be adequately controlled. What to give? Switch regulations in Italy says OT with air filtration mandatory, but in Royal College guideline shows dedicated operation theater, but OT is not mandatory. Before giving injection, surgeons should wash their hands and disinfectants. Surgical gloves should be donned, face masks should be on. Preparation of the drug. As I have given bevacizumab in different eyes, so it should be taken from the vial, and in every cases they are within the syringe, and needle should be removed before injection, and any resistance should be checked before giving. Preparation is in aseptic condition. Preparation of the ocular surface. Pupillary dilatation is recommended. Surface anesthesia given. Ocular surface is painted with povidone iodine 5% and eyelid with 10%. Sterile speculum should be owned. Paracentesis before injection is not recommended if the volume is less than 2.2
Dr.
ml.
Yusuf, you show your experience, please. And we have only 1 minute for you. Your experience, please. Go to the next slides.
We administer by 30 gauge needle. If not available, 27 gauge needle can be injected. Injection at pars plana temporally and needle bevel up and towards the center. Sterile cotton tipped applicator is over the injection site to resist backflow. Give the topical antibiotics post
Dr.
injection.
Yusuf, excuse
Yes.
me. Excuse me, Dr. Yusuf, you go to your that is your experience part, because we don't have much time. We can give you only 1 minute more.
Here, in changes of visual acuity in diabetic retinopathy of different stages, only 5 persons, 7 eyes. There shows the improvement of visual acuity in 6%, that is 85.7%, and deterioration occurs in 1 person, that is 14.3%. And most of the diabetic retinopathy patients are advanced diabetic eye disease, so they are referred to retinal specialist to higher center. And changes in visual acuity in age-related macular degeneration of 3 persons of 6 eyes, all of them have improved their visual acuity. Changes in visual acuity macular edema of different cases, 7%, 8 eyes, all have improved their visual acuity. So there are low complications with appropriate technique. Endophthalmitis is the graded one. And there are special situations. If there is recent CVD, it should be waited for 12 weeks recommended. Periocular infection should be treated before giving injection, and glaucoma is not a contraindication as well. If there is pregnancy, we have to avoid better in first trimester. Second and third trimester, risk benefit ratio should be assessed, and lactating mother intravitreal avastin or other anti-VEGF can be given. Bilateral injections can be given if there are need.
Okay, Dr. Yusuf, we have to finish right now because we have 4 more presenters, 5 more presenters. We don't have much time. Can I ask you to please close your?
Conclude.
Yes,
Okay,
thank you, Dr. Yusuf.